So anyway, I'm kind of like, okay, well, whatever.
Hello, welcome back to our next session on scale-up outcomes and operationalization. Our speaker now is Dr. Cole Hooley. Dr. Cole Hooley is an assistant professor in the School of Social Work at Brigham Young University. His research focuses on scale-up. Specifically, he studies how to get what works to all those who need it more rapidly, more lastingly, and more equitably. Welcome, and I will give the floor to you.
Thank you so much. Just want to do a quick check. Can folks see my slides?
Yep.
Perfect. Great. Let me move over here. Okay. Well, it's a pleasure to be with you. I'm so glad for Dr. Kwan and everyone behind the scenes that puts CopperCon together for even retaining this online option. I was able to participate the last 2 years, and I'm so grateful because I think otherwise I wouldn't be. So I'm so glad that you offered this sort of hybrid option today. I wanted to start this. I'll be presenting work that is an amalgamation of projects that I've been doing, as well as one of the projects, Dr. Catherine Marsal at UNLV. She and I are collaborating, so I want to make sure that to acknowledge her when we get into the system science piece. One of the really cool things I think about dissemination and implementation science and pragmatic science is that we are all coming to this work from different substantive areas and using similar methods and designs and techniques to try to solve pressing health and social problems. My substantive area is mental health services. And so that will be the frame that I'll be presenting some of this information on today, but we'll broaden it out to other areas as well, so it can be applicable to your substantive areas, hopefully. But setting it up, the reason why I am so interested and passionate about scale up within the implementation and pragmatic sciences is given the huge problem that we have. There are so many people who have, particularly now with burgeoning numbers from the pandemic, who need mental health services. The most recent estimates are about 52 million adults who had a mental illness, and only about 45% of those received care. And there might be any number of reasons why a person chooses not to receive care. And so if we were to narrow down that pool to folks who had a mental illness, so they had a need, and then they also perceived that they had an unmet need. So we're peeling away layers to say, yes, they have a condition that would require services, and they're acknowledging that they need help. So if we narrow it down to even that population, about 44% of those did not receive care. And that number, just looking at population-wise, so I live and work in Utah, so that would be like taking the population of Idaho, Utah, and Wyoming and combining them. That's how many people are fitting into this category of having a condition that requires services, recognizing that they need help, and then not receiving it. So not surprisingly, there has been a call to scale up care. And this isn't even specific to mental health services. This is across many social problems and health services, saying, well, we've got some things that work, but how do we get them to all the people who actually need them? So I also want to highlight a paper that was just published under the first author, Dr. Megan Pilar, and a variety of us put together a paper specifically about implementation outcomes that we've learned through this COVID pandemic, and are adding 3 outcomes to the typical taxonomy that many of us are familiar with from Enola Proctor's earlier paper, suggesting that we add in availability. That's a huge issue, especially when it comes to medicines or technologies where there's a finite resource, or even in services where it takes another human to provide the service. We need to know if it's available in order to know if it's something that can eventually be scaled up or even implemented. Equity, of course, is something that is essential. And we've also in that paper suggest adding in scale up, which is distinct from penetration, which has been one of the outcomes in that original paper from the beginning. That penetration outcome really was cast in such a way that it was suggesting within a clinic, within a service agency, looking at the penetration, where scale up goes outside of the agency and suggests, well, we have to look at all of the potential recipients for that given service. So we've also suggested adding scale up as an outcome, and that is just a paper that just got published, I think just posted this last week. So when it comes to today, I want to talk about operationalizing scale up in some different ways that I've been doing it in my work. And we'll be spending the chunk of, I'll give a presentation for the first several minutes. And then as you saw on the handout, I have some questions that I would love to take the opportunity to pick people's brains. Even if you're not in the land of doing scale up work, I would love to just think through and talk out loud with everyone about different ways that we could operationalize scale up in your substantive areas. But first, I want to start by providing a conceptual definition. This is the most used definition for scale up in the WHO in their ExpandNet framework. They have it there, but it predates that work as well. But anyway, this is their definition. It's the deliberate efforts to increase the impact of innovations successfully tested in pilot or experimental projects so as to benefit more people and to foster policy and program development on a lasting basis. CGIAR also added this. I think that's really great and pithy. It's getting more quality benefits to more people over a wider geographical area more quickly, more equitably, and more lastingly. So how do we actually start to capture this population level impact? Tanahashi in the 70s put together a health services coverage framework that works nicely with scale up. In that paper, Dr. Tanahashi points out that in order for a service to ever get scaled, it has to be available first. And so that first rung in that ladder is availability. If and to what extent the service is actually available to the target population. So first it has to exist, and then people have to be able to get to it. And so just because it exists doesn't always mean it's accessible. If there's a very specific treatment for trauma, let's say, and within a given state, there's only one provider, it might technically be available, but it's not accessible to a majority of the population. Then once those who are intended to receive it can get to the service, it's a question of if it is acceptable enough for them to engage with it. And then with them engaging with it, that's one of the primary rungs for scale up is contact coverage. And then Tanahashi goes on to say, contact coverage is like utilization. It's actually coming in contact with the service, getting the service or intervention. But we want people to get more than just contact with the service or utilization of a service. We want them to get better. And so effective coverage gets to that last bit where folks can actually get the health benefits of the service. So this is a framework that has been really useful in our work in conceptualizing the different levels and getting to scale up. And I just am gonna pull up the chat so that I can tend to questions as they come in as well. Oh, great. How would you say, from Russ, how would you say this scale up definition differs from concepts of generalizability or generalization across different attributes of population setting time? Oh, great. Let's see. So I'm going to go back there so I can see where we're at with the definition. And I like the questions just coming as we go. It'll be better to just kind of answer them instead of park them. So thanks, Russ, for showing that and putting it up there. Okay, the from concepts of generalizability across different attributes of populations. Yeah, I think my initial sort of reaction, and please chime back in, Russ, if I'm missing the mark on what your question is getting at, is that the scale up has to be tailored not only to what it is you're scaling, but also to the target population and where they would be receiving this care. And so for me, what I think differentiates this term scale up from other terms is this notion of impact and from the previous session, the sustainment. So it's not just like a one-off. And so I think generalizability, I would view it more as discrete episodes where they have a particular service or intervention for whom a population has been identified, and ensuring that that particular group is receiving it across whatever sectors that they're participating in. And so it might not be generalizable across all populations because that service might not be intended for all populations and all service settings. So it really is a sort of tailored thing. But, oh, great. Let me know if that missed it. Awesome. Thank you so much. Keep the questions coming. I love it. Okay, so contact coverage, effective coverage. Those are two that I'm going to talk more about because that's where kind of the rubber meets the road with scale up towards the end of that framework. So operationalizing these outcomes. So contact coverage is the proportion of the target population served. So for any given service, intervention, innovation, it's this notion of this is intended for a certain condition or a certain group of people. And so what we want to know is how many of those people, so the target population is in the denominator, how many received the service. Effective coverage would be of those people who were hoping to get this service and get well, actually get better from it. And then another key outcome is equity. And so for that, it's taking the demographics or other important salient indicators of the population served, and both for contact and effective coverage, and comparing that with the target population. It's not true scale up if it's uneven, if we're only getting to certain people. It should be across the whole target population. So how do we calculate that? So if we're drilling down and going into operationalizing it, how do you actually calculate it? It's pretty straightforward in many ways. So with contact coverage, it's a proportion. You have the total population in need of a service, and then the numerator is those who use the service. Different types of data that can be useful in these calculations or have been actually used in the literature for denominator. They've used surveys and registries, epidemiological prevalence rates from the literature. In some countries with universal health records and really tight census data, that's ideal and can be used. In Veterans Administration, for example, in the United States, that ecosystem of services also has a health record that can be really helpful with the registry of veterans as well. Then when it comes to coming up with a more refined contact coverage, there has been within this scale up work, the most blunt contact coverage, let's say, is you have a population estimate and then a condition. And you'll say, okay, well, this is a cancer treatment of a particular type. We know that this is the prevalence of this cancer. So that's the group that we're going for. That's one step that you can take, is to say, well, there's a prevalence. Some people go on to say, well, but not everyone with the condition will seek. So there was one particular study in the UK where they tailored their denominator to really hone in on the population that the health service system really could reach. So they had a prevalence estimate. Then they said, of those people, only so many are going to seek services. And then of those who are seeking services, perhaps only a segment of them actually have a condition that qualifies for the care. And then how many of those actually go on to receive it? So they reduced the denominator in multiple steps. Another way that others have done it is taken the whole population that they're interested in serving and then just setting a target. One country said, you know, we're just hoping to reach at least 15% of adults. And so that left them to the 900,000. So when you think about the denominator, there are levels. Some studies just use a blunt population estimate, maybe with the prevalence, and that's as detailed as they can get. But the more tailored the denominator can get, the more specific and more realistic it can be for the health service system engaging in this scale-up effort. The numerator data sources can be program in-house data that just is gathered by the institution. It can be administrative claims data if it's something that insurance uses, and also surveys they've used where they've pushed them out to service recipients and just asked if they received a particular type of service. So this is with contact coverage, different ways of not only calculating it, but sources of data that you could use. I want to show you a paper that we are currently revising, how we tailored our denominator. So it's looking at a suite of evidence-based treatments for mental health specific to youth. And so what we did to make sure that we were honing in on the specific population that the service system was targeting, we started with the initial denominator of youth population based off of ACS census data with specific block groups. And then we took that population, and this particular sort of service is specific to those who have public insurance. In California, it's Medi-Cal. And so we used estimates of those who are enrolled in Medi-Cal and multiplied that by the total population. In order to get this service, the youth also had to have a diagnosis. So we took prevalence rates from a large epidemiological study that done in the US. In addition, this was a preventive program. So it was intended for youth who had not been impaired severely yet by a condition. So we then multiplied that by those who we know to not have severe impairment. And then finally, those who are likely to seek services. So as you can see, if we would have just gone with the youth population, we would have started out with 35,247 youth, saying that's how many youth are in this particular geographic region that could potentially receive services. But when we looked at what this service was actually, who they really were providing for, it brought it much further down to 2,400. And so that was our denominator when we were calculating contact coverage, and then used administrative claims data to see how many unique youth within these geographic regions actually received care. So that's one way that we have operationalized and calculated contact coverage in some of our work. With effective coverage, it's very similar to contact coverage, where you have total population in need of service. And then the numerator here, though, is those who received benefit, not just those who received care, but those who received benefit. So similarly, you've got surveys, registries, literature that can help inform the denominator. And with the numerator for the contact level, it's the same: programs, claims, survey. But then you'll also need some sort of clinical outcome data that would suggest that the person improved. And this is hard, the harder thing to come by, especially in pragmatic ways in large service systems, in my space with mental health in particular, where there might not be a universally gathered clinical outcome measure that can be used. Even in our initiative, clinical outcome measures are being implemented, but they weren't done in a reliable enough way that we could use those data. So we could only calculate contact coverage in our study. But if you do have access to that's where you could figure out, okay, of those who received the service, how many improved as well. Equity, so far in the literature, the scale-up literature, this is how it has been calculated. It's similar with contact and effective coverage, where you're looking at those who received the service, those who received benefit, using all of this sort of similar data that we had before. But then it's taking those data and analyzing those coverage rates, contact and effective, by different indicator groups or by different characteristics that are important for that area and region, to see if there are differential impacts, differential outcomes with contact or effective coverage. I'm just gonna glance over at the chat to see, okay, still good there. I want to capture any questions. When it comes down to thinking about the unit of analysis with scale up, it famously depends on exactly how large of a study you're engaging in. Barker and colleagues calls it the scalable unit. And in their work, they suggest when you're doing scale up work to start by thinking, what is the smallest representative portion of a system that is targeted by full-scale implementation? And so for some full-scale implementation, maybe it's a service that's provided at a district level or at a health ministry level, or maybe it's at a clinic level, or maybe it's a hospital system level. And so for scale up, we would look at what is the scalable unit, the smallest scalable unit that would then be replicated throughout the entire geographic area that would lead to full scale. And then to use that as your unit of analysis to say, okay, well, within this particular intervention, we know it involves a district hospital, a community hospital, and these public health workers. And so that is our scalable unit, that unit right there. And then we will do some testing and using different strategies to see how it works to make sure we're getting to the contact and effective coverage we're hoping for in an equitable way, and then scale that to other health systems, other scalable units. Okay, so we've gone over the conceptual definition of scale up, operationalized it, looked at some ways of calculating it, and then talked about the unit of analysis. Now I just want to move to what are some drivers, what are some determinants of scale up? Within this space, there are a variety of studies in substantive areas across the health services continuum that are starting to get at different empirically validated drivers and determinants. Largely, a lot of this is still coming from frameworks and theory. And there are a lot of frameworks. I was just showing you the expand net. This is another scale up that is just showing a variety of different determinants, as well as these often have processes as well. So I'm just going through a variety of some of these to show there's such a breadth of them. A lot of these are designed in a linear way. They give a nod to say, this is cyclical. It is more than just a linear process, but it's still, they are still very much linear. And so even our work, my earlier work with this is very linear, looking at different determinants of scale up. And so broadly, these are some categories of determinants that we have found in a review. If this were like the regression, if you will, it's like effective coverage being the dependent variable, and then the characteristics of the intervention, of the resource team, adopters, recipients, cost, research, very similar to implementation determinants, I would say. The socio-political context is huge here. The scale-up approach, scale-up strategies, and specific push and pull factors. These are sort of domains that we found in our earlier work, but then wanted to look at them in a more feedback perspective. And so what we used is this perspective that viewed scale-up as a complex adaptive system, which it looks at a system as living. It is lots of components that they have inputs that lead to their own outputs, that create a set of rules that govern the behavior of the overall thing. It's adaptive and changes over time and self-organizing and produces patterns. We saw that this was a good fit for scale up. And so what we wanted to do is create a feedback-oriented framework for, not a framework, but an application of those frameworks and just create a feedback version of them. So we used a hermeneutic approach. We looked through the literature for the scale-up frameworks, reviews of scale-up frameworks in particular, pulled those articles that reviewed the scale-up frameworks, went through a screening process to ensure that we were gathering useful papers. And then what we did is we pulled out constructs from those frameworks and started to map relationships among those constructs. Then we used a thematic analysis on the constructs to put them into categories. And then we started to build a causal loop diagram. We built an initial model after the first reading of a section of articles. And then as we added in articles, we would incorporate non-repetitive constructs and then iteratively built the CLD, trying to strike a balance of parsimony and completeness. So I'm just going to show you some of the versions of that we were going through. We would park constructs up in the top and feed them in. And then if there were redundancies, we would remove them so that we could have a parsimonious model. And so this is the causal loop diagram that we are currently working off of. And what it offers you'll see that it provides our outcomes of interest, the effective coverage we've discussed, contact coverage, and we have equity. So we first plotted those outcomes, and then we've gone through the literature and pulled out different constructs of interest to the scale-up process and mapped out their relationship with each other to highlight the different feedback mechanisms that can happen within a scale-up process. We've then taken that and we are building a hybrid simulation model where our key stocks that we're tracking are the outcomes of interest, as well as this key driver of organizational capacity. And so what we're doing now with our work is we're using synthetic data to test. We will be testing this model to see if we can get it to behave in the way that we anticipate it from a theoretical perspective before we see if we can launch this into actual trials. So this is just another way of conceptualizing these outcomes. And as I mentioned, how we are viewing the operationalizing of it is the proportion in each of these and how these different determinants are influencing the overall flow and the behavior of those different stocks. Okay, so that's a little bit about the conceptualization of scale up, operationalizing it, and looking at different categories of determinants. And so with our time, if there are questions, you can keep throwing them in the chat. Otherwise, I would love to start to hear from you or through the chat from your work. What are, as you imagine this, how could you apply some of this operationalization to your substantive area? I had some prompts in the worksheet to sort of help someone walk through a process, but would be open to folks just saying whatever kind of comes to mind. We have, I think, 7 minutes left in our session, so that's how we'll spend the balance of our time. I'm gonna move over here so I can see you all. And the chat. What are some of the substantive areas that you all work in out of curiosity? You can put it in the chat or unmute yourself if you want. I'm pondering the causal loop diagram and also think about how we could show a diagram such as this with our stakeholders who want to scale up a school-based intervention with, yeah, seems overly complex for them. Question, have you worked on community-friendly mockups to simplify these types of diagrams? That's a great question, Amy. So actually, what we have done in our work is we have co-built these, co-constructed these with our community partners. We've done it with looked after children in the UK and mental health system in the UK, and other sort of work. And so we will bring in those stakeholders and have just a gigantic whiteboard, and we will create a very complex causal loop diagram with them so that as we are building it with them, we do some education so that they understand how to read it, how to look at it. And then when they take a step back, they're able to interpret it. So that's one of the things that I would suggest. But the other thing, sometimes the stock and flow, a simplified stock and flow is much easier to explain to people. To say that there's a thing that we want people to get more of, and it's like, we'll use the metaphor of the bathtub, where these are valves that are things that we can modify to increase the thing we're interested in. And these are things that would decrease the thing. And so that's been one of the methods that we can use to make it much more accessible and to be able to do so quickly. I hope that Amy got to your question. Please chime in if I, okay. Transitions of care. Okay, great. Oh yeah. Yeah. So with us, we have, so with the sustainment, what you're bringing up is really interesting, because what our model is showing is that there could get a point in which urgency of need goes down, where the need for the service goes away such that sustainment is really challenging. And so what we've modeled out here too is to say, well, we think if more and more people are getting better, and those, in your cases, veterans are talking more and more to people, then the system might be more interested to maintain it. They also might demand it more. If the clients are demanding it more, that increases the service system's motivation to continue it. We also think if people are getting better, if we do a better job of disseminating the benefits such that we can get continuing external support, either changing the way that it is billed or building in a budget item, that will increase organizational capacity. So for us, we've kind of modeled out for some key areas that we would start to plug into to hope for sustainment and for additional scale up. Sorry, that's kind of brief, but Roman, I'm happy to talk more offline. Oh yeah, anytime, Amy, thank you. Dennis, working on a project around shared medical appointments in primary care settings, funding, personnel, time, and such an issue. Yes, when do you recommend something this complex? When would a more simple model be useful? So I think for me, it becomes the scalable unit becomes what simplifies the process. So funding, personnel, time, recruitment, etc. If you know you are in a specific setting, you just start with the smallest facsimile that you possibly can and use lessons learned from that setting with an eye towards scaling though. So as you're doing it within that small practice group, you can actually track how much it costs for that whole process, implementation and delivery, to say, okay, well, for this one segment, this is how much time, people, resources, capacity, as we have it in this CLD. This is how much that was. That's to the tune of now we have to multiply that by 10. How is that going to be possible? And so for us, I would start with a scalable unit that is the most reachable, but is a scalable unit so that if you were to replicate that by multiple times exponentially, you could eventually reach full scale up. So I would just start as small as you possibly can. Please chime in if I missed that, Dennis, for you. Oh, great. Awesome. Glad you're in the room. Wish I could be there with you all. Oh, great, Roman. Thanks. I think we have 2 more minutes. Any other questions? Oh, thanks. It's good to see you. Yeah, awesome. Cool beans. Well, if there is any, my contact information, I think, is on all this stuff, but I think I put it here too. Oh yeah. So there's my email. If any of our work can be helpful to you, or you're going through a similar line of thinking that we could work together on and see if we can bring this up, that would be awesome. Would love to collaborate with any of you. As I said, the next steps with our project, we have this CLD. We're in the last rounds of having outside experts validate the models so that we use some literature validation to make sure that the relationships that we had, we could tie it back to the literature, but we're getting expert consensus on it to say that it's worth putting out in the universe, and then working on the hybrid model so that hopefully we can have a fully functioning simulation so that we could play within the virtual space before throwing it out into the big wide world. So if I can be of any help, please reach out. Thank you all so much for being in the room and on Zoom. And I think we have a little break, I think, before the next thing. I'll hand it over to the room.
Thank you so much, Dr. Hooley.
Yeah.
For a great presentation. We'll have about 15 minutes break, and we'll come back to Dr. Bodin's presentation in 15 minutes.